dysfunction syndrome, okay? You know, there are certain, if you get injured in certain areas of the world, you already get those prophylactic antibiotics or antifungals, okay? Because of what we've learned, you know, through work. But this is the distribution. When you think about a trauma and a trauma patient, what can we actually fix? And how quick do we have to do it? Okay? Anybody familiar with the EMS model? Like paramedics, out ambulance wise? Nobody with an EMT? No? Have a couple? Okay. Alright. So I was an EMT before I went to PA school. This is how I got my director hours, so this is the life I live. Basically, when you think about the emergency care system framework, okay, we have the scene, we have the ambulance pulling up, we have the bystander, hopefully, okay, and then, you know, where is that ambulance going to take them? Do we need to fly them somewhere to a higher level of care? Doing that handover, wherever we end up, whatever hospital we end up, okay, what we're actually going to do in that facility, did we actually bring them to the right facility? Okay. Do we have a head injury patient? Do we, you know, sometimes we have to bypass a certain hospital to get to the hospital that has a neurosurgeon. Okay. And then we have the disposition. Okay. It's a big, if you're ever interested in doing pre-hospital stuff, it's very interesting, it's very fulfilling, it's long hours and you know, sometimes not great, but that is the hospital system. Okay. All right, so at the pre-hospital phase, okay, this is the injury site. This is the scene, okay? The goal is to get the patient to the right hospital as soon as possible, okay? And we want to try to get them to a hospital that has definitive care. Sometimes that is not always possible, but for the most part, right, just like I said, if we already know that this person has a head injury, right, and it's going to take us 5 extra minutes to get to a hospital with a neurosurgeon, we're going to do that, versus trying to take them to a community hospital that doesn't have a neurosurgeon just to stabilize. But if they have a belly injury, maybe we go to the community hospital first, stabilize their belly, give them blood, and then get them airlifted to a neurosurgeon. It all depends. Okay? So, those PHTLS and ATLS are the two main you know, first responder courses that we have. I've taken both. Has anybody ever taken PHTLS? Couple. How many ATLS? Couple. Love it. Okay. ATLS is what the American College of Surgeons has deemed the course that all trauma providers need to have. And then when we talk about medical control, right, is we have pre-established field protocols, okay? Every hospital or every region has an EMS director, okay? And they have specific protocols in which that region has to follow, okay? If we go to a different hospital and it has a different medical director, sometimes we have to talk to that medical director to get their protocols and what they want us to do in terms of in transport, okay? It does vary. Not every system has the same protocols. So radio communication with the physician at wherever hospital, and then the subsequent trip audits, those are like they have to, just like we have to do a patient report, they have to do a patient report that then gets screened and reviewed by their medical director or whoever they delegate to do those peer reviews. Okay? So it's a checks and balance system just like we have. All right, when we talk about triage, okay, this is normally when we talk about mass casualties, okay, triage is to sort. We try not to get overwhelmed, but a lot of times we do. Okay. What is the definition of a mass casualty?
Exceed the resources.
It exceeds the resources, okay? If you are at a little tiny DAS, and you have 2 critical patients walk in, guess what? You have a mass casualty. Okay? It all depends on the resources you have at that facility. So this is why we have this. Okay? You must for your next test, be able to determine if that patient is a immediate, a delayed, a minimum, or expectant. And we will go through them. Okay? So these triage tags, every time I've ever been on an employable unit, we've had these. Okay? Has everybody seen these tags?
Negative.
Negative? Okay. These are the triage tags that are normally given out when we have a mass casualty. Every hospital has them. They are pretty much standard across. They may vary slightly, but the immediate, delayed, minimal, expectant, the red, yellow, green, black are, I've never seen it anything different. Has anybody ever seen it different? Those who've seen it before. Okay. So I think these are pretty standardized so that no matter where you are, if you were trained as a triage officer or a triage person, okay, it's all the same. All right. So in terms of setting up your triage area, okay, whether you're out in the field or next to a hospital, okay, you have to figure out like where you're gonna have the best traffic flow, where you're gonna have adequate space to set up your tents or your area, right? Depending on how many beds your immediate area can hold, depends on how big the tent and how big the area must be. Okay, you want to try to have it in proximity to the landing zone, okay, or the ground evac area. You don't want to have the ambulance, 100 yards out, and then them having to, take the patient 100 yards. Like, you want it closer, right? One way of flow traffic. Okay, you have an entrance and an exit. That way they always go the same direction. It eases the confusion and congestion if you have one entry and one exit. Okay. Should be well lit, should be covered, okay? Should be easily identified and marked somehow. Okay, I think when I was on a mission, I think it was in South Korea, we took a plywood and sprayed like a red X and put that outside our tent so that everybody knew we were medical. Okay. Recorders, if you have like a hospital administrator or some sort of administrator or foreman or whoever's good with numbers, dedicated recorders. Okay. The hardest part of doing triage in a mass casualty is keeping track of the patients. Okay. You must be able to follow a patient A all the way through triage, treatment area, OR, post-op, wherever, okay? But if you have 20 or 30 or 100 patients, you must be able to follow each of those patients. So having a recorder is key, okay? And then people who can actually help move litters. We call them the manual laborers, but say you are with a Marine unit or another Army unit and you have other people in that unit that aren't injured, pull them in. Be like, hey, I need you to help me with this patient over there. They're going to be their buddies. They're going to want to help. Give them a job. Plus, it keeps them out of the way. If they have a specific job that you give them. All right. Normally we have one senior triage officer. It's normally an experienced provider, but that's not always the case. That's what we try. Anybody know who the normal triage officer is? Dentist. Right? Whoever made that model, I don't know. But yeah, so the normal triage officer is a dentist. Okay? If you do not have a dentist, normally the ER doc or the surgeon will normally step up and be that triage officer. The EM doctor is normally the best if you have multiple ER doctors or multiple providers, because if the surgeon has a surgery, there's normally only one of them. If they have a surgery case, they're going to be in the OR and not helping out in triage. If you have two ER docs, one can be triaging and one can be actually in the treatment tent. Okay. We do no treatment in the triage area. Okay? We don't want to have congestion in that drop-off zone. Okay? We try really, really hard not to have treatment in that area. Okay? Now, if they're spurting blood, we put direct pressure on it. We can try to put a tourniquet on it, but realistically, if they're dropped off and they're spurting blood, they're immediately put into the treatment area and a tourniquet is then placed. Okay? We try not to do any treatment in the triage area. And then in terms of where or what code of the triage they are, whether immediate, delayed, minimal, or expectant, depends on where they go. Okay? So immediate. Okay, we'll go through this, but immediate normally goes straight into the tent. They're unstable, they need care right now, they're going to pass within the next few minutes. Okay, to 2 hours, right? They're unstable though. Delayed is they're going to need some sort of treatment, but they're stable, right? They have shrapnel to the belly, but their blood pressure and heart rate are normal. They're not in signs of shock yet. They need treatment, but they're not the sickest people. The green or the minimal are the walking wounded, and then the expectant are those who are already have passed or would most likely exceed the resources that we have. Okay, so say that's an 80% burn and we only have 20 units of LR, or 20 bags of LR. Probably going to need a lot more than that, so that we may put them into expectant. They have a huge head injury, okay, with exposed brain, but they're still breathing. We may not be able to treat that, okay? The biggest thing is having separate areas. So they drop them off, you have the expectants go around a corner where the other, patients can't see them, but there's a provider over there constantly checking on them. Immediate go into the tent, and then the non-emergent or the delayed kind of goes off to the side so that they can still move into the immediate tent if they decompensate or when it's their turn. And then the walking wounded area where it's away, but again, they're still getting checked, they're still getting seen. Like when I was at Lejeune, the immediate went into the ER, the delayed went into fast track, the minimal went into family practice clinic, and the delayed went down the hallway where lab is. Okay, all very close to each other, but we had a disbursement pattern that would not be congested. Okay. So when we're doing field triage, okay, there's 4 main things. Okay, we want vital signs and level of consciousness. Any anatomical evidence of injury, okay? Do they have an amputation below the knee? Do they have shrapnel to their chest? Do they have, whatever anatomical injury you can see? What their mechanism of injury was. Was it a blast? Was it an IED? Okay, did they fall? Did they get shot and then fall off a building? Right? Did they get shrapnel and then blown up against a wall? So now they have both blast and blunt. Okay? And then any specific patients or systemic considerations, okay, which we'll go into. And then you really need to try to figure out who needs that higher level of care. Trauma center, okay? We try to move the sickest people out first. Okay, talking about triage again, immediate, okay? Like I said, these people are, requires attention within minutes to 2 hours. Okay, these people are unstable, they need treatment now. Okay, these people are the most dependent upon what we do at the scene that will determine their outcome. Okay, if we do not fix or recognize their airway obstruction or compromise, obviously that we have determined their outcome. Right? If we do not fix that tension pneumothorax with a needle beat or a finger thoracotomy, we have determined their outcome. Okay, it's not going to be good. So we try to fix the things that we can fix quicker and quickly. Okay. But these are the things that you should be thinking about when it comes to immediate. Okay, they are the sickest. So when we're trying to manage those priorities, okay, stopping the bleeding, putting tourniquets, strip pressure, and working the static dressings on, okay, securing the airway, so doing an OPA, MPA, supraglottic intubation, or if they need an ET intubation, if we're going to ventilate them or not, okay, how are we going to restore circulation, do they need blood? In terms of trauma, it's either blood or nothing, okay? Assessing their GCS and their splint, if they need splints, okay? So X, A, B, C, D, E. Okay, everybody has heard that before. Have you guys started your trauma EM?
Yes.
Great. Cool.
We have that test right before yours.
Lovely. So this is nothing new. And then you all have your March. Everybody remember March, right? Acid hemorrhage, airway, respirations, circulation, head injury, hypothermia. Okay? These are the two algorithms in which you must always think about when we're talking about trauma. Okay, delayed. We have the wounded but stable. Okay, blunt penetrating trauma that will need surgery but no signs of shock at this point. They have facial injuries, but they don't have airway compromise. Plus or minus float injuries, plus or minus life or not life-threatening burns. Okay, but they're burned, they need help. Yeah, so their vital signs are stable, but you know that we're going to have to do something. Okay, minimal, those are those minor injuries, normally perform self-care. These are the people who normally overwhelm the resources because they can bypass the medevac, okay, and then self-report to the hospital. Not normally the case in a war zone, okay, but when we have a mass casualty in the civilian world, these are the people who really clog up our system because we just can't get them, they just self-report. Okay. Expectant, these are the non-salvageable injuries or would require a vast majority of supplies. Okay, they have no vital signs on arrival, they have a transcranial GSW, and they are in a coma, so they're still breathing, they still have a heart rate, but they're unarousable. They have a GCS of 3. Okay? Shock, severe burns, and any high spinal cord injuries. Okay. We do not abandon them. Okay, we place them out of sight, but we frequently reassess and try to provide comfort measures, and if we get everybody through immediate and delayed, and we still have resources that we could potentially save them, then we will do everything in our power to save them. Okay? Always reassess your patient. Okay? Anytime you roll them, anytime you move them, anytime you change beds. Okay? Do you think patients are going to wiggle on the bed?
Yes.
So just because they haven't moved from bed to bed or from imaging to whatever doesn't mean you don't need to reassess. Okay, this is the number, I don't know, number one, but it's very, very close to the top of reasons that people have bad outcomes is because we forget to check these things. Bandages migrate, tourniquets loosen. You know, someone who had a patent airway got a little bit of morphine and no longer has a patent airway, and we didn't check, right? So always reassess. And then again, categories can change. So a good example of this is when I had a mass casualty at Lejeune. It was, I think, 2021. We had one of the big transport vehicles flipped on the side of the road, and a semi hit them. We had some already DOAs. I was in charge of helping with the delayed and some walking wounded. I was called over to walking wounded to do a belly exam. He had a little bit of pain, but he was walking, talking, GCS 15, had no other like signs of injury, didn't even have any bruising. Okay. Ended up getting a CT, and he had a grade 3 liver laceration. So he was in the hospital in the ICU for a day, maybe 2 days, while we watched him. Okay, so even the walking wounded could be critically injured, and because their bodies, especially young, healthy military people, right, they can compensate really well until they don't. Okay, so any signs of belly pain, chest pain, we always work those up. just so that we don't miss it. If we had sent this guy home, would the risk of him having a complication happen? Probably not, because he didn't need anything while he was in-house. But God forbid he actually did go home and bleed worse and we missed it. Okay. All right, so when we're doing a medevac, okay, the 9-line medevac is an old, that's the way I learned. Now currently we use the MIST report. It's a lot quicker, a lot more succinct. Some, if you're really into other, like actual military casualties, some may need the 9-line depending on where you're at. But for this class, we're just going to do the MIST report. Okay? So mechanism of injury. So were they in a car accident? Were they shot? Were they in a helicopter that crashed? Were they in a Humvee that got blown up with an IED? What injuries do they actually have that you can see? Symptoms, vital signs, okay? Symptoms including shallow breaths, GCS, whatever, okay? And then what treatments you need them. All right, so hospital phase, when you're trying to prepare, okay, advanced planning. When you get to wherever you're going, figure out what your mass casualty plan is for the hospital, okay? Know where to go. See when you do mass casualty drills in most hospital systems, okay? Just for this reason, because if you can plan and train to it, then when it actually happens, it's less chaotic. Practicing your handovers, making sure that they're smooth and seamless. And most of the time they're directed by the trauma team leader. And then when we can, if we can get a report prior to the patient's arrival, that's really key. Then we can kind of get an idea of what things we may need. Okay, if it's a chest injury, we'll get the chest tube set up. Or if we already know it's a going to tuck into the belly, we already let the OR standby. Okay. And then knowing what personal or PPE to wear. Okay. Pretty self-explanatory for PPE unless you're in a hazmat type situation, in which that's a different class. Alright, so we already talked about ATLS, okay? When we talk about primary survey, ATLS puts out basically the guidelines in which they think trauma should be run, okay? They're pretty much accepted guidelines throughout all of trauma across the country, pretty much across the world, okay? There are classes in which we have other nationals come in and actually take our ATLS course, especially military members. There's other, like emergency force, surgery course, or the Asset Plus course. We do have other national military members come in and take these courses with us. Okay, so again, this is probably all repeat. ABCDE, okay? The biggest thing is adding hemorrhage, massive hemorrhage in the beginning, right? If they are pulsatile bleeding, putting a tourniquet on or direct pressure on first, okay? We want to stop the bleeding and then go ABCDE, okay? Because bleeding, like you saw on that first slide, right? Minutes to seconds to minutes. If we can stop that massive hemorrhage with either a junctional tourniquet, a normal tourniquet, even direct pressure, packing the wound, we can do anything we can in order to stop that bleeding. They have a better chance of getting, to the next step. Okay? So again, sanguination, first step. Okay? Airway, does it need an airway or not? How do you think is the best way in order to ask or to assess if that patient needs an airway or not? Talk to them. Yeah. Right? Hey, what's your name? If they talk back in a coherent sentence, they probably have a good airway, and they're probably just not having any mental status changes. So you kind of did see right off the bat, right? And you C-spine precautions. So what kind of injury patterns do you think will need C-spine precautions? MBA, falls, pretty much anything that could potentially injure the spine, right? There's a lot. Okay. What about that patient who can't respond? They're already altered. Do you think they get C-spine precautions? If they can't tell you their name, they can't tell you who they are.
Yeah.
Absolutely, because if they probably don't remember what happened to them, okay, putting that C-spine precaution on is not gonna hurt them, okay? Breathing, looking at the symmetrical, rise and fall of the chest, what injuries do they have to their chest, what bruising do they have, any chest wall tenderness, what's the respiratory rate, okay? What's the rate in which we intubate?
GCS less than 8.
Not GCS. Respiration rate? Low. What's the low one?
Less than 10.
Less than 8.
8.
Remember that? It's a very cool, it rhymes. Respiration rate of 8, intubate. Okay, if it's 8 or lower, you intubate because they theoretically cannot protect their airway. Okay, they're not breathing enough to sustain oxygenation to the brain. Okay. And then in terms of tachypnea, it really depends on if they're leading to respiratory failure. Okay. Sometimes we can use like a CPAP or a BiPAP to try to get them through. Sometimes just angiolytics can help, pain control can help. Okay. If they are already in respiratory failure, like we talked about the last block, then we can intubate. Okay. Circulation. Okay. Checking perfusion. So this is really critical in terms of if you're, in the field or even in the ER. Where are 3 critical places you can check for a pulse that can also correspond to what their blood pressure would be? Carotids, femoral, and radial. So what is their blood pressure normally at if it's a radial pulse? 80. What about femoral? 70. And carotid? 60. Okay. GCS. Did you guys talk about GCS yet? Lovely. I really need to get with understandable. All right. Pupillary response is a big one. You try to do GCS and a pupillary response before you knock them down for intubation. Okay, so at the airway, we have decided as a team that we need to drop a tube and intubate them. Someone on the team, normally the right side of the bed, will try to at least get a GCS on them, okay, and a pupillary response, because once we push those RSI meds, that goes away, okay? So if we can get a baseline that one pupil is blown or both pupils are both reactive the same, right, before we intubate, before we push those meds, the better the patient care we can give, okay? And exposure trauma naked is a thing, depending on what type, it doesn't really depend on what type of injury they have, unless it's just like a stubbed toe, right? But if they are in a massive or major trauma, okay, we are going to undress them. We are going to look for in every nook and cranny, their armpits, their perineum. We may do a DRE, okay? Every nook and cranny, to make sure that we did not miss any bullet holes or stab wounds or shrapnel wounds or anything like that, okay? All right, so primary survey made easy, okay? You have 2 most rapid causes of death: loss of airway, massive bleeding. So those are the 2 things that we try to do first, okay? If you're on the airway, you're dealing with airway, the head of bed. If you are either right or left side, clavicle down, you are trying to stop that massive hemorrhage first, whether it's with direct pressure or tourniquets, whatever. Okay, talk to your patient on arrival. Try to assess their airway. Try to assess their mental status. Get them naked. Okay, roll them over, looking at the anterior and posterior surfaces. That is your primary survey. Okay, in a nutshell. Now, getting labs normally happen during primary survey, but we run them and do any other adjunct tests. So their chest and pelvis x-rays, which we do on every single trauma patient. We do a EFAST, and we get the labs run between their primary and secondary surveys. Okay? So if on a test, I said, when do we want a chest and pelvis x-ray? It'll be in between the primary and secondary surveys. Okay? We need to address X, A, B, C, D, E before we do those tests. Okay? All right. this is just a good algorithm if you guys like algorithms, in terms of like where we do fast exams and you know, if they have a response to fluid resuscitation, then we can move on to secondary survey. If they don't, we need to do something else. Okay. When we're talking about a critically ill patient, okay, these are the types of shocks that you need to be just aware of. Okay, if they're cardiogenic shock, these are the types of injuries that you'll see. Okay, attention to a thoraces, maybe needing a needle or chest tube, all the way to abdominal trauma. Okay, and then all that is. Okay, if you like algorithms, there you are. Okay, trauma team roles. Okay, normally led by a trauma surgeon, sometimes ran by the EM attending. This picture did not turn out the way I wanted it to. I'm gonna apologize. But they are the ones in charge. The attendings are the ones in charge. Okay, the trauma team can include anywhere from just one resident, 2 residents, maybe a few nurses. Okay, hopefully you have enough people to satisfy all of these roles. Okay, but sometimes you don't, and you just have to make do. Okay, so in the lead is the trauma surgeon. They normally stand at the feet and watch. They are normally the collector of all the information to try to make the best determination. Okay, you have the head of the bed. You can either be a respiratory therapist, or I'm sorry, a CRNA, a anesthesiologist, or a EM resident normally, or an ER doctor. Okay, they're the ones in charge of basically the clavicles up. They're trying to assess the airway, checking the mental status, pupillary changes, as well as intubating if that is deemed what is needed. Okay. The right side of the provider normally does the clavicles down, and or puts in an IV. Okay, if the person comes in and the IV is on the left, the right person is putting in the other IV, and so forth. If the IV that keeps coming on is in the right, the person on the left is going to do the left IV. Okay, so it really just depends. They're normally, if you can have 2 people on each side, or 1 person on each side. Okay, you have 1 person doing one side of the body, the other person doing the other side of the body. You still have someone putting on a monitor. Okay, so you kind of have those conversations before the patient comes in to say, okay, right side, you're going to do the monitor. Left side, you're going to do clavicles down, or if the monitor is on the right side of the patient, okay, it's on the left. It's just having those conversations before that patient ever comes in, so you and those providers know exactly the roles in which they have, so it's seamless and it moves very fast. Okay. Hopefully you have a scribe or someone taking notes. You have a circulating nurse who's administering medications, and then anybody who's ancillary staff, your radiology techs, portables. You have your medical techs, hopefully, other nurses, photographers sometimes. I've never had a photographer come down unless I asked them to. But this is like the normal team roles. And where they normally stand when we actually have a trauma. Okay. Alright, so patient arrives, we get the report from EMS, we try to listen, we ask questions, we get them on the bed, and then EMS leaves. Okay. We try to remove their clothing as we do the primary survey. But the primary survey really starts immediately. Okay. We can get whatever the EMS tells us, but we're still doing our initial look too. Okay, we're never just going to take what EMS says as face value, because things change, or they may miss some. They can't get people naked en route most of the time. Okay. Now, once the primary survey is done, we get the chest and pelvis X-ray, we do the EFAST and all the labs that we want to run. Then the secondary survey starts. Okay. When you think about the surveys, right, these primary and secondary surveys, primary is looking for the ship that's going to kill them fast. And then trying to provide those interventions so that it doesn't kill them fast. Okay, once we get them stabilized, then we can do the chest and pelvis X-ray, the EFAST, run whatever labs we want. If we want to go to CT, we'll go to CT. okay? And then the secondary survey starts. Secondary survey is a full head-to-toe comprehensive exam. You are going to try to find the things that will disable them. We missed on primary survey, like a broken ankle, okay? Hip, potentially a femur fracture. Normally we find those on primary. But the little things, okay? Those are the labs. So remember, 2 blocks ago I said we don't do rainbow labs. Trauma is different. We do every single one of these labs on every single trauma patient. Does not matter. Okay? These are the labs we order every single time. CBC, CMP, coags. Okay? If they're truly, truly sick, we'll get an ABG, especially with lactate. If it's maybe a green or maybe even a delayed, depending on how sick they are, right? If they're talking and they're awake, we may just do an EBG. If we sense any respiratory type issues, we'll get a UA, we'll get a urine tox, blood tox with ETOH. Now, blood troponin, okay? Those are if they have cardiac or in the cardiac box trauma. Okay. And then plus or minus HCG if they're a female of childbearing age. You get that on every female of childbearing age. Okay? Because we're about to probably send them through a scanner with a lot of contrast, and we would like to know if they're pregnant or not. Okay? And then, so chest x-ray, pelvis x-ray, okay? We do those on every single trauma patient. Okay? The only time it would change is if they have a very focused injury. Okay? They were caught in industrial machinery and it was just crushing their leg. We probably don't need a chest or a pelvis. But if they complain of a pelvis or chest pain, we'll just do it. Okay? So those 2 things may change depending on how or what the actual injury pattern is. If they just, got a cut to their thigh from a chainsaw, right? It's a very focused injury. We probably don't need a chest or pelvis x-ray. Does that make sense? We'll still get an x-ray of that femur, or of that leg, or of that arm, depending on where that focus thing is. But if they have any injuries from within the thorax, abdomen, pelvis, they're going to get a chest and pelvis x-ray. Okay? Abdominal x-ray plus or minus really depends on, it doesn't really do much in the way of showing any bowel injury. Okay? But if they were shot in the belly, we need to be able to find that bullet. Okay. Otherwise, we're just going to go to CT. So we'll get a CT abdomen pelvis with IV contrast. Okay. Any obvious fracture points, we'll get long bone X-rays, length on the X-rays, and then the FAST exam. All right. Hemorrhage control. Okay, we all talked about tourniquets already, remembering that it's 2 to 3 inches above that injury and not over a joint. Direct pressure hemorrhage control. Okay, if it's just oozing or non-extremity bleeding. Okay, if it's really high junction, we can do junctional tourniquets, but if it's more belly, chest, we try to do direct pressure. If it's somewhere that, like again, dark blood that's oozing versus bright red pulsatile. Pulsatile gets a tourniquet, oozing gets direct pressure, possibly packing up that wound. Okay? We don't remove the gauze. If we do direct pressure, we just add more gauze to it. Okay? If we are adding so much pressure that it's just a lot of, we're just constantly, we can't get any control, we can either do a pressure dressing with an H bandage, an Israeli bandage, okay, or just put a tourniquet on if you have a long transport time. Okay, and then hemostatic agents. Again, we have the combat gauze that we can use. We just don't put combat gauze on the brain. Do not put combat gauze on the brain. All right, we have a 66-year-old man who done with landscaping injury. He was pruning bushes with motorized shears when he slipped, cut his right thigh, put towel around the wound, and was able to walk to the emergency department. No other injuries, vital signs are normal. He takes warfarin with for a fib. Exam of the wound is 7 centimeters, simple superficial laceration with dark blood, continuously oozing from the defect. No underlying tissue damage. What is the most appropriate next step?
Third question.
I'll say A, B, C, D, E. Good. B. Direct pressure. Good, good. Okay. Alright, securing the airway. Making sure that we have patency. What is the method in which we open the airway in an unconscious patient? Jaw thrust. Alright? If they are already in a seat collar, do not break their neck there. Okay, we do jaw thrust instead. If you do not know, or do not, if you suspect any sort of neck injury, or potential for neck injury, put them in a collar and do a jaw thrust. Okay? For blunt, we always assume an unstable cervical spine exists. Okay? But again, you know, can they answer you what's their name, or what is your name, and they answer in a normal voice. It's not hoarse, it's not stridorous, it's not gurgly, okay, it's not short, staccato type, you know, they can't speak in their normal speech pattern, okay. We'll look for signs of obstruction, foreign bodies, debris, okay. If they have evidence of major facial fractures, tracheal injuries, okay, if we are suctioning, you know, we're looking for blood versus clear secretions, okay. But if at any point you think that their airway is compromised, do not hesitate to knock them down and put a tube in. Okay, so we talked about MPAs and OPAs. MPAs, nasal trumpet. You measure that from the nair to the earlobe. Okay. We put this in if they have an intact gag reflex. Okay, so they're kind of unconscious-ish. They're kind of like moaning, okay? They still have a gag reflex. You're not going to put it in OPA, right? You don't want them to puke. You put it in MPA to help them breathe, but they're still potentially needing more. The only other absolute contraindication is basilar skull fracture, okay? You have bruising on your mastoids, raccoon bruising around your eyes. I would, you know, bleeding from the nose, bleeding from the ears. I would not put it in OPA or an MPA. Okay, you do not. This is a CT reconstruction. Okay, I think this is actually an NG, nasogastric tube, but it's in the brain. Okay, don't do that. And OPAs, okay, you do that from the corner of the mouth to the ramus, the pointy part of your jaw. Okay. Now, when you put this in, you start with the curve to the roof of the mouth, okay? Then when you go in and as you insert it, you turn it 180 so that it's getting above the tongue. It's weird, but it works. Okay? Alright. Supraglottic airways. So, out of the 3 airways that are here, only 2 are definitive airways. Okay? Endotracheal and cricothyrotomy. Why does this matter? Okay? Definitive airway secures an airway below the vocal cords. If it does not go below the vocal cords, it is not a definitive airway. Okay? So supraglottic, okay, basically just sits at the base of the throat. Part of it goes into the esophagus and blocks the esophagus, but the main air, the hole actually goes over the trachea and supplies air that way. Okay, this can get dislodged. This can still have aspiration risk. You can't tell definitively if the patient is getting good respirations or not. Okay, and if they have an intact gag reflex, you don't do this. You're going to make them puke if you put this in if they have an intact gag reflex. Okay. Normally for ET tubes, okay, we're putting it in either by direct visualization or wide scope with indirect visualization. Okay. and we want to try to place it 2 centimeters above the carina. And you can tell that on a chest x-ray by measuring the vertebral bodies. Okay? You see the trachea, you see the carina, the Y, okay? That middle part is the carina. If you measure at least 2 vertebral bodies above the carina, it's normally about 2 centimeters above. And we all know about cricothyrotomy, correct? Surgical airway, okay? This is our last resort. It can be very, very bloody. We try not to do it if we don't have to, but this is an emergency type procedure. We cannot get a direct airway, okay, from the top, so we have to go through the neck. All right. Breathing, okay, can be anywhere from simple oxygenation with a nasal cannula, non-rebreather, all the way to being on a vent, okay? This is nothing new, right? Listening, auscultating, potentially doing percussion, trying to figure out if there is a thorax type of pathology that we need to act upon, right? Knowing what those massive injuries that would, lead to death quicker. So tension pneumothoraces, massive hemothorax, an open chest wound, sucking chest wounds, a flail chest with severe compromise of their ventilation and oxygenation, okay? Severe pulmonary contusions, okay? Think of basically it's a huge bruise, a blood collection in the parenchyma, so instead of edema, it's blood, a huge bruise. Very hard to oxygenate through that. Severe head injuries, that's high spinal cord injuries. Why high spinal cord injuries? We're talking about thorax, why do we want to know about high spinal cord? Right? If they take out 5, 2, 3, or 4, you're really not going to have that drive because that is it lower? Normally it's higher, but when we go through the neck injury lecture, it'll be specifically stated in that. Okay. And then anybody who has suspected hemopneumo should get decompressed immediately. Okay. So this is slightly different than just your normal like chest effusion or edema, right? There's a lot of more things we do more quickly than running that fluid for labs or that kind of thing. If they're a trauma patient and we see fluid in their chest, we always assume it's just blood. Okay. Have we been surprised when we put a chest tube in and it's serous sanguinis or some sort of other type of effusion? Sure, but not very commonly. All right, go take a 10-minute break. Okay, we only have like 15 more slides-ish, and then because I had a couple people come up and ask me about the test, are you guys good with spending a few minutes, like 5-ish minutes, going through some of the test questions that a lot of people are going around? So that when you go out to phase 2, you kind of know what to do? Maybe? Okay. All right. Well, let's get back into breathing life emergencies, right? Life-threatening injuries, okay? So what is a flail chest? Flail chest is at least 2 fractures per rib and at least 2 ribs in a row, okay? So basically you have a section that you have like an anterior and a posterior break on the same rib and sequentially. Okay, so you basically have like a section of rib that is no longer attached to the rib cage. How do you know? Because when they take a deep breath in, it actually moves in instead of the rest of their chest going out, okay? And then when they exhale, that piece comes back out. Does that make sense? So it moves interdependently with the rib cage. Okay? How do you, what's that?
Oh,
Paradoxically, yes. Right? It really disrupts that normal pulmonary mechanics, okay? So how do we fix it? We put a bunch of gauze and try to tape it over and try to like do a stent or a splint there over the area, okay? We want to admit these people, okay? We will most likely do a rib fixation, okay? Meaning that rib plating, okay? To try to fix that pretty quickly before a lot of scarring takes place. Epidurals for pain management is great in these patients. Okay, gets good regional blocking. Because this is pretty painful. All right, closed pneumothoraces, right? we're gonna do either 20 to 40 French. Okay, so either a small bore to a large bore tube. If there's blood present, we're more so going towards the large one. Okay, if it's just air, which in trauma is rare. Okay, normally with rib fractures we got some bleeding, so normally we go 28 to 38. Okay, but if it's just air, we can put in a tube thoracostomy, a chest tube. Okay, if it's starting to evolve into a tension pneumothorax, and you are nowhere near being ready to put, you don't have a scalpel on you, you have needle D, you're going to do a needle D. Okay? Normally we do them in the second intercostal space, mid-axillary line. The other place is the fourth to fifth intercostal space, mid-axillary line. Or mid-clavicular, mid-axillary. Okay? Now I know in some instances, some will say anterior axillary line. As long as it's between anterior axillary line and mid-axillary line, okay, that's pretty sufficient. Okay, so somewhere on the sides. Okay. When do you go and do like a finger thoracotomy? We normally don't do a finger thoracotomy unless it's like dire, like they are about to lose pulses or they've lost pulses. Okay. They are already in tension physiology. We are showing signs of that cardiovascular collapse. Okay, and that's if you don't have a needle decompression. Okay, when we are in the trauma shock room, most trauma departments who are a big trauma center will have a room specifically for people who are coming in with either impending cardiac arrest or are in cardiac arrest. We have all of our surgical sets in the room. Okay, all of our other devices, our internal defibrillator paddles, lots of scalpels, lots of lines. Okay, and actual major and minor surgery kits or sets in the room in case we have to do surgery in that room. Okay, and in terms of surgery, the biggest, we're never really going to go into the belly. The biggest one is going to be that open thoracotomy. Okay, basically going from sternum to bed. We start on the left. Okay, we want to get delivery of that heart. Make sure that you know, if there's any bleeding within the lung, we can either twist the lung on itself on its hind limb or try to clamp it down. Okay, if we don't get any blood from that side, we'll open the right. Okay, while someone is doing the thoracotomy on the left, someone is doing, which was normally my job, the finger thoracotomy on the right. Okay, if I got blood out of that, normally then we would connect and do a clamshell. Okay. So, in terms of pneumothoraces and that kind of thing, yes, the real book answer would be needle thoracotomy, or needle decompression, finger thoracotomy. If you don't have a tube present, then to a tube thoracostomy. Okay? Every needle decompression and every finger thoracostomy is going to end up in a chest tube or a tube thoracostomy. Okay? If you put a hole inside the chest, you're going to get a chest tube. Okay? Now, sometimes if patients are stable, we'll get radiographic evidence, we'll get a chest x-ray to see if we need to do anything, but if they are actively crumping in front of us, actively in cardiac arrest, we do not wait for chest x-rays, we just go in. Okay? Time is muscle, time is bleeding, right? So we try to just figure out, you know, what is the thing that is going to kill them the fastest, and tension pneumothoraces or cardiac tamponade. Okay, we want to relieve those. We can do, if we've already delivered the heart, we can do intracardiac muscle epinephrine injections. We can internally shock the heart. We can do internal compressions on the heart. Okay, there's a lot of things that we can do in the meantime to try to get their vitals back, to then go to the OR and try to fix whatever's happened. Okay. Normally when we do a emergency thoracostomy or thoracotomy, right, when we open up their chest, we're actually cross-clamping the aorta so that the blood that's in their heart goes to the brain and the lungs, but nothing below that. Okay. We don't leave it for very long, but that at least gives whatever blood they have in their main system, right, blood and lungs, or heart and lungs, the brain, then we can get them back and get them up to the OR. And that's a lot of times if they have a huge abdominal injury and they're bleeding out in their belly, that stops the blood from going into their belly. Okay, there's no blood going past that clamp into the periphery. Does that make sense? Okay. Have you heard this before? Kind of? Ooh. Silence. That means that you haven't heard that before. That's nice. Okay. And we've all talked about sucking chest wounds, right? We want those commercial or any type of steel device, sticky, something with a vent so that if air goes into the chest, it can leave the chest but not go back in. Okay. You have a 27-year-old tall, thin male, pregnancy emergency room with moderate right-sided chest pain, dyspnea. Started quickly while watching television 30 minutes ago. He's tachypnic. However, his heart rate and blood pressure are stable at this point. Lung exam reveals after breath sounds over his right lung, which of the following other physical exam findings would be expected in this patient? So what does he have? I wouldn't say tension. He has a pneumothorax, right? A right-sided pneumothorax. He's tachypnic, but his heart rate and blood pressure do not show any signs of this, like, tension physiology at this time. Okay, so what other things do you think you're going to find on this patient? Do you expect them to have decreased right-sided tactile pruritus? Yes. Okay. What about left-sided hyperresonance? No, because it's on the right. Okay. What about mediastinal shift to the right?
No, because that's tension.
And then tracheal. If this was starting to go into tension, which side would it go to? Left. No.
On the
So the carina is right there. Okay. Pretty straight on. Okay, maybe slightly, but he could also be turned a little bit. I would call this a normal variant. Okay. If it got any worse, it would probably shift more. But I wouldn't necessarily call this true tension physiology. Okay. All right. And then, are you going to hear muffled heart sound? With just pneumothorax? No. What do you hear muffled heart sound with? Tamponade, cardiac tamponade. Very good. So the answer is decreased right-sided tactile pruritus. Good. All right. So we want to restore circulation. Okay. This is the next priority in the primary survey. Okay. If you have someone who has a broken leg, you try to and no pulses in the foot, you're going to realign that leg. Okay. Oh my gosh, my brain just went dead. Sorry. We want to put them in a splint that kind of realigns it, as well as we can pull traction on it. We can put them in a traction splint if that helps. Some orthopedic surgeons like it, some don't. Just all depends on the surgeon you're working with. Okay. Anytime you have a limb that has an obvious deformity, you must be checking the pulses past the site of injury. Okay. If they have weak pulses or no pulses, is that good? No, right? That can lead to a critical ischemia. So you have to do something right then and there, some intervention, whether it's just straightening it out, putting in a splint, putting it in traction. Okay, something has to change in order to reestablish blood flow as soon as possible. Okay. This also includes the initial assessment of circulation, so blood pressure. Most surgeons will want you to get a blood pressure before we turn them. Okay? Because if they are super, super hypotensive, we will get blood and we will wait to turn because they're unstable. Okay? We want them to be stable enough that they can handle a turn. Take a look at the backside. Okay? We already went over radial pulse. Normally, if you have a radial pulse, you have a blood pressure of 80 or higher. Okay, I would know those. And then the biggest thing is when you have a patient's level of consciousness, right, and skin perfusion, it is a very good indication of their hemodynamic status. Okay, so if they are thinking clearly, they know their name, their skin is, pink, dry, Their CAP refills normal, okay, their hemodynamic status is pretty normal, right? Versus if they are pale, mottled, they're diaphoretic, they're cold, okay, and they're confused, they're most likely in a stage 3 type of hemorrhage. Okay? Everybody remember this one. I told you you'd see it again. Everybody remember this. You learned it once. Hopefully you don't have to learn it again. Okay? Repetition is key in terms of trauma. Okay, especially with the classes of acute hemorrhage, I would absolutely expect this to be on the exam. Okay? Knowing if I give you a patient presentation that falls within certain levels, okay? But now instead of just classification, it's, okay, now you need to know what state they're in and then what to do about it. This is adding to that, okay? So the answer isn't going to be, most likely, what class they're in. It's, you need to know what class they're in, and then what is the treatment of choice. As a fair warning, okay? Hemorrhagic shock is a condition. It is reduced tissue perfusion, resulting in inadequate delivery of oxygen and nutrients that are necessary for cellular function. That is the classic definition of hemorrhage, okay, or of hemorrhagic shock. If you are in hemorrhagic shock, right, and blood, we give blood. Why? Because we need those cells and those nutrition, or the clotting factors, everything, to try to bring their body back to a normal level. Okay. So, for fluid resuscitation, we want some sort of large bore IV. Okay? If we have somebody in a class 3 hemorrhage, we are giving blood within 20 minutes of them arriving. Okay? They need blood. Blood out equals blood in. Okay? We no longer give any isotonic crystalloid. None. Now, EMS may if they do not have access to blood, but as soon as they come in, we stop that crystalloid and put them on blood. Most trauma centers have a blood fridge in their shock trauma room, okay, with at least a couple units of whole blood, so that we can start blood immediately. If they don't have that blood fridge, they normally are the blood bank is normally one of the first ones who gets notified that we have a major trauma coming in, so they get a few packs of whole blood ready and brought up to the trauma shock room. Okay. So what types do we have? Low molecular or low titer O whole blood. Okay, that is the best one we have. That is the best one we can use. It has all clotting factors. That is the standard. That is the gold standard. Low titer O whole blood. Okay. If we need to, we can do type-specific whole blood. We need to do at least a type and screen in order to figure out what type to give them. Okay, we only have component therapy is 1:1:1. So 1 unit of packed red, 1 unit of platelets, and 1 unit of fresh flow plasma. If we only have plasma and red blood cells, we'll do 1:1. Sometimes we can just do red blood cells alone. But the biggest thing is excess crystalloid is shown to worsen trauma-induced coagulopathy. Okay, so we don't give fluid that's not blood. Okay, we do some sort of component or whole blood if we can. Okay, all right. When we're talking about flow rates, okay, this is to give you a good idea of how much we can actually put in and why we say at least an 18 gauge in both ACs. Okay, with at least one 18 gauge, we can put in 100 milliliters a minute, and we can do 1 bag of blood in 10 minutes or less. Okay, if we have a 14 gauge, we can do 250 per minute, and we can get that in 1 liter in a quarter. Okay, versus if we look at our lowly, triple lumen that we use in our sepsis patients, the flow rate is really low, 30 mLs per minute, and so it takes about 34 minutes to get in a liter. And that's why we don't use triple lumens in trauma. Okay, most of the time we will put in a Cordis. Okay. We can put a lot of blood, a lot of fluid through very, very quickly in a Cordis. Okay? Cortices we can put in any central line places, so IJ, subclavian, and femoral. But this is a good, like I would know just generally, okay, the smaller the gauge, the more fluid we can give. Okay, so if I give you like what has the greatest flow rate or what will give blood the fastest, know that order. Okay. All right, this is a good JTS, this is from the JTS guidelines for damage control resuscitation. We'll talk a little bit about this when we go through the abdominal catastrophes. Okay, but this is just a quick overview of what we can do in triage, what we do for hemorrhage, what we do for resuscitation, and then for medication administration. The biggest thing is if we give blood, most normally when we get to either 6 units of packed red blood cells, we'll give calcium. Okay, the citrate in the units of blood will cause a precipitous drop in their calcium, so we normally just preventively give them calcium. This is every 4. Okay, so it's every 4. I don't know, 6. Normally it's 6. Yeah, 4. Okay. Normally when we get to like massive transfusion, which is 6, which is probably why I have 6 in my head. So you say 4. Okay, so this is just a quick reference guide if you like that type of thing. All right, when we're trying to decide, say we have both whole blood and component therapy to our advantage, okay? And we're trying to decide on who we're going to give whole blood to, who we're going to give component therapy to, okay? You got to look at what it can actually give, okay? So when you have component therapy, you have 1 unit of packed red blood cells, 1 unit of platelets, 1 unit of FFP, and 1 of cryo. That's about 680 milliliters, okay? Normally, you can get like your platelets up to 80,000 and 60% of your coag factors, okay? But if you're talking about whole blood, it is a little bit lower in volume, but you can really get a bump, a substantial bump in your actual coag panel, okay? Like your CBC. So your hematocrit goes up almost to 50%, your platelets can go up substantially, and your concentration in your body will be replenished. Okay, so whole blood is really the one of choice that we want. So say you have a major trauma, okay, you're going to get the whole blood. Say you just have someone like that chainsaw to the leg, he's not in that class 3 shock, but he needs a little bit of blood, we're going to give him most likely component. Okay. All right, disability. Should know how to calculate the Glasgow Coma Scale. We try to do this rapid neurological assessment, okay? Giving them thumbs up, wiggling their toes, they follow directions, okay? The only problem with GCS is that it's the best score of all 4 limbs, okay? Eyes and vocal is pretty normal. You really can't fake that. But with their motor score, right? Say they have an issue with half their body, okay? Half, like they're either on a stroke or they have a sharp cord dissection, okay? Half their body isn't working, but the other side is, and able to follow directions. They still get a 6 out of 6 motor score. Okay, even though they have deficits on one side, it doesn't matter. It's their best score. So that's not the best way. APVU is something that is has been used very historically, and is the trauma or the ATF call that I just got conference that I was in last week. They're actually starting to use this more so in TCCC because it's a lot easier, a lot faster to use. So are they alert? What's their verbal score, what's their pain, and are they on the phone, right? So APVU is coming up again to kind of replace GCS. The biggest thing with GCS is if you have a T, so a GCS of 8T, okay, that means that they're intubated. The lowest score you could possibly have is a GCS 3T. okay? They're basically a pencil that is intubated. Okay? You cannot have a GCS of 0. Okay? So if their eyes are not opening, they are no verbal response and no motor response, they have 1, 1, 1, so 3. Okay? And if they're intubated, you just add a T. That's, again, another reason why GCS is falling out of favor.
I mean, the highest is 11
What's that?
I mean, the highest is 11 The highest score.
So,
if it's
I mean,
intubated.
in terms of, he's asking the highest score with the T. I have had people who I've marked as a 15T, only because they are awake, they can write and legibly, like they're still intubated because they're in ARDS or they're trying to still get over the respiratory process, but they're awake and coherent, they can answer questions, they can answer yes or no, you know, so like if they can interact with me, technically they're not vocalizing it, but they're with it enough that I really consider that they're answering questions absolutely correctly. They know their name, they know where they are, whether they're writing it, they want the TV on, they want the lights off. Like it's as if they were talking, but they're only trached because they're whatever. They're still getting over their lung issue, and they just haven't been able to get off the vent yet. Okay, so theoretically, maybe book answer would be 11T is the highest you can get when you're actually intubated. But the longer you're in medicine, the longer you can kind of, you know, not fudge numbers, but it's more so take all of it into perspective. And if they are truly oriented, they just can't speak because they're intubated or on a trach. Because most of the time they can cover their trach and talk, or they can talk through their trach. Okay, so it's depending on where they are in their care, kind of depends on the level. But I have marked people as 15T because they're still within their healing process of their lungs, but they're able to coherently converse with them. Okay, again, disability, looking at that furlough, looking at the symmetry, the biggest things are if you have a blown pupil, okay, if you have a herniation, okay, it's going to correspond to the ipsilateral injury, okay? So if you have a herniation on the right, your right pupil is going to be blown, okay? Versus if you have a lateral gaze with the dilated pupil, that means that the brain herniation went through the tentorium cerebelli, okay, right there, okay? So it's basically the cerebellum is herniated versus the cerebrum is herniated versus the cerebellum herniated. Does that make sense? We'll talk way more about that when we get to the neuro lecture, or the head injury lecture, but that is just a good, if one side is blown, it's normally that side that is herniating. Okay, 19-year-old man presents to the emergency department after a motor vehicle collision. He is unresponsive, he has irregular respirations, and a unilaterally dilated pupil. His heart rate is 45, his blood pressure is 90/60, and his SpO2 is 76. What is the most appropriate next intervention, initial intervention?
Intubate.
Who wants A, B, C, D, E? Right. We want to intubate them, right? Irregular respirations unilaterally, so he's already herniated, his heart rate is shit, his blood pressure is shit, and his SpO2 is shit. So, he needs an ET2, he needs a definitive airway. That's the first thing, right? Any questions on this? Also, when you get to, like, whoever hasn't taken, like, has everybody taken BLS? Yeah? Okay. ACLS and ATLS and ABLS, all of the other ones, you've got a taste with BLS, but these are the types of questions that they love to ask, right? If you know your ABCDE, you're most likely going to be just fine, okay? Because they are trying to ask you, like, what is truly the next step. If they haven't gotten intubated yet and they're looking like this, you have to intubate them first before moving on, okay? Even though you were like, no, I need to fix whatever, you got to intubate them first, okay? All right, exposure, that trauma naked, okay? We still want to try to prevent hypothermia, so we cover them up as soon as possible, but we need to look at every single nook and cranny. We have to turn them, okay? We will find bruising. We will find tire tracks over their back, okay? It all just depends, okay? But looking at their axilla, looking at their perineum, in between their butt cheeks, in between their skin folds, you know, everything. If you don't look at everything, you're more likely going to miss something. All right. Disposition. So you have a trauma patient. We went through the primary secondary survey. Now what? Okay. When do we rush to the OR? What procedures do we need to do in order to get there? We will go through those individually when we go through the systems. Okay. We have to always consider who's going to sign the surgery consent, who's going to sign the blood consent. Can they get blood? Are they a Jehovah's Witness? Okay. There's certain things that we need to be thinking about when we talk, or when we are thinking about going to the OR. When and what advanced imaging do we get? Okay. Trauma likes to do a pan scan, but it is still patient specific. Okay. Not everybody gets a CTA of their neck. Okay. CT angiogram. Who thought I made a typo on the exam, by the way? We'll go over it in just a second. We're almost done. All right. But what type of CTs do we get? When do we add contrast? Okay. Are there any special tests that we need to do depending on their mechanism? Okay. When we're done with them, are they able to go home? Are they stable enough that they just need to go to the floor and wait for their ortho surgery the next day? Are they going to be a step down because they need a little bit more help but not ICU level care? Okay. What type of ICU? Are they a neuro? Right? Do they only have a head injury and they need to go to the neuro ICU? Normally they don't go to the cardiac ICU or the medical ICU. Okay? It'll either be the surgical ICU, the trauma ICU, or the neuro ICU depending on what's happening. Vascular patients love to go, or vascular loves to put them in the surgical ICU because that's where all their other patients go. But normally they end up in a trauma ICU if the hospital has a trauma ICU. In terms of downgrade, okay, so when a patient enters the hospital, right, they're brought in by EMS, they are labeled as a certain category of trauma, okay? Normally it's either a level 1 trauma or a major trauma, or we have a level 2 trauma or a minor trauma, okay? Some hospitals have a level 3, it just depends, but normally when a person comes in as like a level 1 trauma, they have to go through all level 1 things, okay? It's after that they're done, okay? They have no actual physiological injuries. There are some hospitals that will allow us to downgrade them to just normal ED patients. Some hospitals don't let us do that, but if we can, then they go back over to the normal ER, and or we just disposition them from a trauma standpoint and send them home. Okay? A lot of times these are falls that don't end up actually injuring them. Certain car accidents, okay? A lot of algorithms, or a lot of hospitals, like when I was at Cook, if the car was going more than 30 miles an hour, it was already a level 1 trauma. 30 miles an hour is not that fast. So we have a lot of level 1s that didn't have any injury, right? But we are going to be, there's a certain regulatory type things that we get checked on. Every trauma system, ECS, checks on. And if you don't have those listed correctly, right, we under triage those patients, we get in trouble. We get less in trouble for over triage, so we err on the side of caution and just triage them over. Does that make sense? Okay. Alright, so downgrading sometimes if we have it, okay? Doing all the things that we need to, they can go home, closing those lacerations, doing those washouts, reducing those fractures, calling ortho, putting them in a splint, getting them set up for their ortho follow-up, whatever. Okay, it just depends. Alright, so summary, right? We have the primary survey. Okay, we're trying to catch those life-threatening injuries. We're doing the XABCDE. We're addressing life, limb, eyesight. Okay? Secondary survey, we're trying to catch those secondary or less threatening life-threatening injuries. Okay? We want to do those histories, a full history, you wanna know their meds, their allergies, like just like if you were doing a normal H&P, okay? We're gonna do a head to toe, full on comprehensive exam. If we, denote something in that head to toe exam that we didn't see in the primary survey and we need to get additional imaging, so we will get additional imaging now, okay? And then consult any specialties that we need to. Okay, so orthopedics is bone, right? Neurosurgery is brain. Vascular is any vessel. You can call ophthalmology. We normally don't call optometry. Normally we call the eye surgeons, the ophthalmologists, if we suspect any kind of globe type injury. The ENT. Sometimes the ENT, or if we have a facial fracture, they like to share their call with plastics as well as with OMFS, the oral maxillary facial surgeons, which are basically like dental surgeons. Okay? So if you have a facial injury, you have 3 people to call depending on who's on call that day. And then tertiary surveys, so this is normally done after 24 hours. Okay, if we send these people home that day, we're not necessarily doing a tertiary. We will still do a once over right before they go, but normally like a full-on tertiary survey is someone is in the hospital 24 hours after admission, we do a head to toe. Okay, normally their adrenaline's out of their system, they're starting to feel pain. We'll catch the broken scaphoid fractures, we'll catch the little things that we didn't catch the first 2 times around. Okay? Alright, any questions on welcome to come on? No.